name's Dr. Lawrence Cox. I'm a junior doctor at Brighton and Sussex University Hospital in the UK, and I also work with the uveitis service at Moorfields. You can see in the bottom left here a nice dense cataract. So just a quick overview of what I'll be talking about today. I'll do a quick revision of lens anatomy just to make sure that everyone's familiar with that. I'm sure we're all very up to date on that. And then I'll be doing an overview of the timeline of cataract surgery, talk about a few different types of cataract surgery from Cushing to extra and intracapsular extraction, and then talking about more modern procedures as well as intraocular lenses and where things might go in the future and moving forward. So lens anatomy, I'm sure we're all very familiar with this, but you can see a nice diagram at the bottom here. This is a axial section through the lens, and you can see there's an anterior pole, a posterior pole, and an equator. Along the anterior pole and around the equator, you can see the epithelium, and the epithelium produces these circumferential cortical fibers that you can see. There's the cortex and the nucleus. Obviously, the most common cataract that we see in the UK is age-related cataract, and that's a result of nuclear sclerosis, changes in the crystalline proteins, which are responsible for transparency, and also deposition of pigment and pigmentation of the lens proteins. So here's a quick timeline giving you a overview of basically all the way back to 1,000 years BC. The top timeline is, as I mentioned, all the way back to 1000 BC. The bottom timeline is just a bit more zoomed into about the last 300 and 350 years to make it a bit easier for everyone to see. The earliest records we have of cataract surgery are 500 years BC, when Cushing was first performed. And that was sort of predominantly the main procedure that we saw up until fairly recently, really the last 300 years. And in 1747, the first extracapsular extraction was performed, shortly followed by the first intracapsular extraction 6 years later in 1753. Most of the developments then occurred in the last sort of 50 to 70 years, with the first intraocular lens in just before 1950, development of phaco and ophthalmic viscosurgical devices as well. You can see this red dot here is modern day 2021. So Cushing. The word Cushing actually comes from the French verb coucher, to sleep. And I believe this refers to the patient's position during the procedure, which is usually supine. You can see a nice picture of Cushing being performed at the top here. Obviously, the patient is sitting up here, but in the majority of cases, the patient will be supine. As I mentioned earlier, the earliest records that we have of this are the 5th century BC. And in fact, the cataract is not actually removed, as you can see in the bottom right here. Rather, a needle is inserted through the cornea, and the cataract is basically pushed back into the posterior chamber, and it just sits in the vitreous. The patient's obviously left aphakic. The main problems here are a lack of aseptic technique, huge numbers of cases of endophthalmitis, and a lot of patients being left with very, very poor vision or no vision at all. Unfortunately, this is still practiced today, as you can see here. So this paper was published in 2013 in the Nigeria Journal of Medicine, and it's basically a case series describing a number of patients who underwent Cushing in southwest Nigeria. You can see, as I've highlighted at the bottom here, sadly, only 25% of eyes maintained any vision at all beyond 10 years. Just wanted to say a quick word on Galen of Pergamon. This was a gentleman who lived in ancient Greece in the 2nd century BC. A very, very interesting man. And if you have time after this presentation and after this lecture series, I definitely recommend looking him up, doing a bit of reading about him. He was a anatomist, surgeon, and a philosopher as well. And he performed probably one of the earliest precursors to modern cataract surgery by inserting a bronze instrument into the eye and actually removing the lens by suction, as opposed to obviously before with Cushing, where the lens was just pushed backwards. So on to more modern procedures now. Obviously, extra and intracapsular extraction being the main sort of modern techniques. The first documented extracapsular extraction was in 1747 by a French physician named Jacques Daviel. And here, as you can see in the diagram in the bottom left, the lens capsule remains in situ and just the cataractus lens itself is removed. The main problem here is that a large corneal incision is required, with a 10mm incision being made, or sometimes more than 10mm. The lens capsule is obviously punctured and the cortex is removed. So a bit more about the history. This gentleman on the right here is Jacques Daviel, who I mentioned earlier, performed the first extracapsular in 1747. There are some documents which suggest a similar kind of procedure may have been performed much earlier in 600 BC by an Indian physician named Sushruta, but records are inconclusive, and certainly the first official extracapsular extraction was 1747. The procedure, while better than Cushing, still had a fairly low success rate at only 50%. And this was primarily due to poor wound healing, infection, lens remnants left within the lens capsule, and posterior capsular opacification, which obviously they didn't have the technology to deal with effectively at the time. Even though intracapsular extraction was first performed only a few years later in 1753, extracapsular extraction remained sort of the primary technique used up until the 19th century. So onto intracapsular extraction. Here the lens is removed along with the capsular bag through a large limbal incision. So unlike extracapsular, here you're removing the entire lens capsule. And obviously to do that, you're going to need to tear or pull the lens away from the zonular fibers somehow. Initially, this was just done with forceps and manually pulling the lens capsule away from the fibers. Later on, cryo extraction became a bit more popular. So this was first performed in 1753, as I mentioned earlier, by this gentleman on the left here, Samuel Sharp. The gentleman on the right here, Joaquin Barraquer, actually started using alpha-chymotrypsin, and this helped dissolve the zonular fibers, reducing the trauma of obviously pulling the lens away from the zonular fibers. And he first did this in 1757. Unfortunately, because of the loss of the barrier between the anterior and posterior chamber, there were a lot of side effects, including retinal detachment, corneal decompensation, and macular edema as well. And for this reason, it gradually lost popularity. Modern cataract surgery was completely revolutionized by this gentleman on the right here, Charles Kelman. Again, very, very interesting man who sadly passed away in 2004. And he was the first gentleman to use phacoemulsification, whereby ultrasound is used to coagulate the lens protein and make it much easier to extract. Shortly after, ophthalmic viscosurgical devices were developed. These are basically space-occupying gels containing molecules like hyaluronic acid, usually inserted into the anterior chamber during cataract surgery. In 2008, femtosecond laser-assisted cataract surgery was first performed in Hungary, and this was approved for use in the US by the FDA in 2010. The idea of this is to make smaller corneal incisions, neater surgery, less corneal astigmatism, but currently the evidence is lacking a little bit, and it's still inconclusive whether femtosecond laser is actually cost effective and really improves surgical outcomes. First of all, I'd like to just say a quick word on manual small incision cataract surgery. This is increasingly popular in the developing world because of its low cost and lack of need for expensive technology. There's also a very small incision, which is a self-sealing sutureless wound. We can't talk about modern cataract surgery without mentioning the development of intraocular lenses. In 1949, Sir Harold Ridley was performing cataract surgery, and his medical student, in fact, remarked to him whether it was possible to implant an intraocular lens into the eye. He had recently seen a load of fighter pilots from the Second World War, and he'd noticed that they tolerated fairly well small remnants of plastic or shrapnel in their eye. And this got him thinking about implanting a lens in the eye. So he developed a PMMA lens, which was implanted into the anterior chamber. But obviously, because of the position, a lot of patients actually went on to develop uveitis glaucoma hyphema syndrome. In the 1970s, the intraocular lenses gradually moved backwards into eventually behind the iris and then into the capsular bag. In the 1980s, foldable lenses were developed, which obviously allowed much smaller incisions to be made. And then toric lenses and multifocal lenses in the 90s. And in the early 2000s, we started seeing accommodating intraocular lenses as well, to compensate for the fact that removing the natural lens, you obviously lose the ability to accommodate. Cataract surgery at the moment is extremely good, but it's not perfect. And a few developments that we might start to see in the future are the ability to post-operatively adjust intraocular lenses. So there's a few papers which have been published, particularly on the use of UV light. And this basically allows us to reshape the intraocular lens and slightly modify the refractive power of the intraocular lens if patients are left a little bit too myopic or hyperemetropic after surgery. This can also be done mechanically or magnetically. Other intraocular lenses might include astigmatism correcting lenses, as well as developing the use of intraoperative aberrometry. These are my references. If you're interested in having a further read, I definitely recommend checking out this paper at the top here, published in Missouri Medicine, The Evolution of Cataract Surgery. This was the main paper that I used for this presentation, but there's a few other papers there which might be of interest to you. Thank you very much, everyone.